y'all.
Oh, okay.
How are you guys? It's good to see you. Did you try your exercises with the band?
I grabbed some.
Okay.
Yeah.
The band was good. That's it's getting stronger. So Isabel and Mike were here on Wednesday. Ted's taking up residence here this year on Wednesday. And it's good to see you again. Thanks for coming back. And we'll have a couple on Zoom. Well, anyway, everyone knows me, but I'm Kate Campbell, and I am the program manager of the Parkinson Center. And I just want to highlight, we have a lot going on. This was a really busy week. We had an event on Monday, introducing our center to a senior living facility. We had our social event on Wednesday, talking about adaptive equipment. What a good opportunity to buy some items for the holidays. And today, Dr. Rodriquez talking about diagnostic testing, which we get those questions all the time. So why not hear it from the expert? We still have our support group at the end of this month. Another special addition there is Dr. McAllister, is another neurologist, movement disorder specialist, but he does clinical trials, and he has a special clinical trial coming up. And so he's going to speak at the support group at 2 o'clock, and then we're going to do our support group at 2:30. So come early and expect to stay a little bit later. I think it'd be really interesting to hear what he has to say. And then in December, we're starting a second support group because of our high demand for Zoom only. So it's an opportunity to attend twice a month, one in person, one on Zoom, or if you're just a Zoom person, you can access it that way, led by our social worker, Meredith Beanan, and a fun event, a holiday sing-along. So when I presented this to our multidisciplinary team music therapist, they're like, yeah, we'll sing some songs. But I have a friend who has Parkinson's and he plays keyboard, and oh, this patient wants to come and need our guitar. I think we're going to have a full band. It's going to be so much fun. So, and they have music therapy interns. So we do want to get a good turnout because there's a chance there will be more people playing music and leading than actually in the audience. So please come and spread a little, what is, I'll say the way to spread Christmas cheer is singing loud for all to hear, right? So we'll do that in December. And then deep brain stimulation by Dr. Connors. Yeah, he does deep brain stimulation along with other movement disorder specialists in the area with a patient advocate who has gone through the process to talk about their experience. Pros, cons, questions. That's going to be a really fascinating talk. So put that on your calendar. The sheet says TBD for the time, but it is actually at 12:30 on. I can check the date if you're interested. It's on our calendar. It's definitely up on our calendar. And that's it. That'll take us through the rest of the year. And I think that's enough. But then January always has more. And we're looking to start our next boot camp cohort at the end of February. So if you're interested, let me know. And with that, let's bring on Dr. Rodriquez to give the presentation.
See you, is that okay?
Yeah.
So good morning, everybody.
Good morning.
And thank you for inviting me for being here. I wanted to thank RDNA Health, not only for inviting me, but also for hosting events like this. I think it's always a pleasure for us to talk about Parkinson's disease, spread the word, give access to more resources, and the more we learn about it, the better off we are. So for those who don't know me, I'm Bernardo Rodriguez. I'm a physician at UConn Health, and I'm a movement disorder specialist. I'm the director of the Parkinson's Disease and Movement Disorder Center. We also have a training for the next generation of neurologists. So we have a fellowship in conjunction with Hartford Healthcare. So it's a big endeavor, and we're always training the next generation. The idea, both from us and all the other institutions, is to try to train more and more doctors to provide earlier and earlier diagnosis, better and better management, and hopefully retain these doctors here in Connecticut. We're actually hiring one of the fellows off Yale, so this exchange is very healthy. So we're very happy. So today we're going to be talking about the diagnosis, and I think this is going to be a presentation you guys can go back to, you can record, and you can share. because it doesn't matter if it is a new diagnosis for you or if you have had Parkinson's disease, there is always the question, what exactly do I have and how exactly do you know what I have, you know? So today I'm gonna talk to you guys and kind of show the behind the scenes situation of what do we know and how do we know it and how we do it, you know? So and why do we do this? Why do we need to know what exactly we have, you know? So we're gonna be talking all of the fundamental basic science that is built every day. So every time you hear about a clinical trial, we're trying to learn a little bit more about the condition and see if that will make us better diagnosis and better management. So I always like to start with this statement by Samuel. Sam, right? Sam for us. He lived here in Connecticut. And we have a Mark 20,000 in Hartford. Which is you have to be sure of what you're saying, you know, and sometimes it's easier for your doctor to say, you know, I don't know what you have. Because if he tells you that you have essential tremor and you actually don't have, that can be painful. So a lot of times you're gonna hear kind of vague expressions such as Parkinsonism, and you're like, why didn't you commit to Parkinson's disease? It's just because it's safer. You know, we don't want to mislead you into a certainty that we don't have yet. But we're gonna be trying to put the pieces of the puzzle together so we have a better understanding why this happens. You know, so what do we know? I guess we're gonna start with what we know. What we know about the disease. You know, so there are certain things that we know, and we look for those when we interview you, when we examine you. There's a lot that goes behind the scene, funny enough, and I don't want to reveal the secrets of the trade, but I think that the take-home message is that you're always on camera. You know, your doctor is observing you from the moment you walk into the clinic. You know? Everything you say, everything you behave. So it's much more than open and close your hand and stand over here. There is a lot that happens as we converse. And also, we're going to talk about the diagnostic criteria because they have to be developed to increase accuracy again. And I think that the most fun part is the future, right? The new technologies. And what are the things that can help us with that? So everything that we do now, and there is this saying that we're standing on the shoulders of giants, right? So this is a building technology, you know? So in the 1917, 1817. In 1817, Dr. Parkinson's, he described a disease. He didn't call it Parkinson's disease, that would be weird. So he didn't call it that, he called it shaking palsy. But 50 years later, Jean-Martin Charcot, which is considered the father of neurology, he named Parkinson's disease. And he also described the main three features of Parkinson's disease, which is the tremor, the stiffness or rigidity, and the slow movements or bradykinesia. So we have fancy words for everything. So tremor, stiffness, and slow movements. And this was Jean-Martin Charcot, and we're talking like 1860s, 1870s, that he already saw this, and we still can see it's very reliable. 50 years later, Dr. Louis, he described finding these weird bodies inside the brains of people. And we're like, okay, what is that? And then we're like, okay, there's also this substantia nigra thing. So we're getting the pieces of the puzzle. And eventually we're like, oh, this is an ocean. This is a boat in the ocean, right? So collecting these little pieces is what makes us do the diagnosis of Parkinson's disease. At this point, we know very well that dopamine is the main neurotransmitter missing in Parkinson's disease. And we know that alpha-synuclein is a very important protein that is associated with this pathology. So a lot of the diagnostic tests will revolve around the substantia nigra, the dopamine, the alpha-synuclein. So you will hear this like, oh, this protein is very important. Why? And what can we do about this protein? This protein is now at the core, at the center of all studies for, not only for diagnosis, but also for treatment. What happens if we treat this alpha-synuclein thing? So this is how we build stuff. This is the classical article that Dr. Parkinson's published in 1817 with a series of cases and described very well the main core triad, which is the tremor, the stiffness, and the slow movements. I use fancy words there. Charcot, he was the director of neurology in Paris at the PTA Salpêtrière Hospital, and he had a bunch of famous neurologists there, like Dr. Freud, who became a psychiatrist, and Babinski, and Romberg. All of these people, they were residents of Charcot. So Charcot is very, very famous. He not only named Parkinson's disease, but he also named and created multiple sclerosis. He really created all of neurology. So this is how the Lewy body looks like. Is this pink round circle is an inclusion body. And for years, almost 100 years, we knew that it was there. The Lewy body is a marker of cell death. Meaning, if you see a cell, if you see a neuron, a brain cell with a Lewy body inside, that cell is about to die. We still don't know if it is a chicken or the egg. It's about to die because of the body, or the body formed because the cell is already about to die. It took us 100 years to find out what is inside the Lewy body, which is now very well known as the alpha-synuclein protein. So this is a cross section of the midbrain. The midbrain is a part of the brainstem and is considered to be the main area that produces dopamine. And you can see that is black stuff, substantia nigra on the right here is very black, but on the left is kind of pale. For some reason that we still don't know yet, patients with Parkinson's disease start losing those cells and the substantia nigra becomes less black. This is a picture from a classic movie, I think it's called Awakenings, where they describe the whole journey in New York City, close by here, how they found out that dopamine was the missing ingredient and how dopamine really changed and would change the lives of many, many millions of people with Parkinson's disease. So, like I was referring before, Maria in 1997, she and her colleagues, they were able to describe the malfunctioning in the alpha-synuclein that would lead to the Lewy body aggregation and would lead to pathology. So this is a pivotal article, and it's very interesting because these regularly normal and functional protein can misfold and actually become the problem. So we're trying to figure out ways of preventing this misfolding and making sure that the alpha-synuclein does well. But it's good to see where it goes. From the classic triad, now we do 4, because we found out even 1817 when James Parkinson described that balance is also affected in Parkinson's disease. And it's very disabling. If your balance is off, you're going to hesitate to exercise, you're going to be afraid. And if you fall and have an injury, it really changes the course of your progression. We want patients to be very active, exercise a lot. Should I speak loudly? I think it's good. So I did my fellowship in Michigan. Go Blue, go Husky, go. And when we see somebody, you see how we're asking her, hey, how are you, and everything, we're already seeing that the left hand is shaking much more than the right hand. And this asymmetry of onset already points towards Parkinson's disease. But as we're asking her to show her hands in different weird positions, we're also looking at facial expression. You see how her lips are open, her mouth is partially open. And also we look at blinking rate and the speed of movement, okay? So the finger to nose is a classical test of coordination. But in this case, we're also observing how fast she's able to do that, finger to nose. And you see it's very, very different one hand from the other. Also the lack of movement, you know. We humans are very restless, we're very uncomfortable, we're always moving. And if you look at her, she's very quiet, very not moving the legs, not moving almost anything. And so now we're gonna point towards the feet and we're gonna try to review the speed of movement, the amplitude, you know, how wide she can move the feet. And sometimes we ask patients to stop the feet, and sometimes we ask them to just tap the toes. So a lot of you guys will be familiar with pieces and bits of this exam because this exam eventually became standardized. And there is a questionnaire that follows this exam called the UPDRS, which stands for Unified Parkinson's Disease Rating Scale. So a lot of times your doctor will be doing this. He will not grab a piece of paper and say, hey, let's do this questionnaire. He's already burned into our everyday activities. So we're just gonna go through. So this is a full test and she did well, she recovered, so her balance is still pretty good. So funny enough, we gave her dopamine. And look at her hand. It's not shaking as much. And the speed and the blinking, even the head motion as she speaks is more. A lot of people ask me this, especially new patients, how quickly can you see that? Well, as quickly as 15 minutes. Back in the day when I started doing this, we used to hit people with huge doses of dopamine. And then they would see the response right away. Well, nowadays we're very careful and we start with teeny tiny doses. So it's possible you will not see a response because the dose is just too small. And it's just because we're being careful. We don't want you to have any side effects, especially nausea, which is the most common one. But the response typically is very fast. A lot of times we bring patients to the clinic off medications, and then we give a huge dose, we call that a dopamine challenge. And then we wait 15 minutes and we repeat the exam. And that's basically what she's having here. Because she was being tested for deep brain stimulation, right? So when you're doing these evaluations, you want objective measures, you know? I think it's important for patients to tell us how you're doing, how long does it last, how long does it take to kick in. But it's also important to get that on camera in a very objective way, measure how fast they can move, how fast they can go 10 feet or something like that. So this, as you guys are getting a hint, is a very clinical diagnosis, meaning I look at it, I feel your muscle. But I didn't apply any tests, and that is all. We receive second opinions all the time, and they come from hospitals here in New Haven, like, how could, you know, she didn't even do an MRI or anything. Well, it's a clinical diagnosis, so seeing how you move, how you talk, how you walk, a lot of times is enough. The difficulty here is that Parkinson's disease has 5 other siblings. It has other 5 other versions of itself. And some of them involving alpha-synuclein, some of them involving tau protein. And they're very different, and they have strange long names that we abbreviate into DLB or MSA or PSP. But they have very unique features that are not typical for Parkinson's disease. So we name them atypical Parkinson's disease. And just to give you an example here, dementia with Lewy bodies, which is the first one on the list. It's weird. It's not typical. It doesn't behave normal. You know what is not normal about dementia with Lewy bodies? Dementia. You don't expect a patient with Parkinson's disease to have dementia, especially not in the beginning. So if you see somebody with Parkinson's disease and they have dementia in the beginning, it's gonna like, I don't like this. This feels funny. And typically that's how you make a diagnosis of Lewy body. It's a combination of dementia and hallucinations. It's also not common in Parkinson's disease. So there was a release of a medication for hallucination in Parkinson's disease, and it was all over TV ads everywhere. And patients would come to me and say, well, hallucination is pretty common, right? No, they're selling a product. You know, they want you to be alert and they want you to believe it's common, but it's fairly rare. Multiple system atrophy, for example, patients with Parkinson's disease will have a lot of drops in their blood pressure. PSP, they will have a lot of double vision and falls. People will not be able to walk like 5 years into the disease. And that is almost unheard of in Parkinson's disease. So Parkinson's disease, you should be able to walk pretty much for the next 20 years, 50, but we don't care. But PSP, you will have a lot of trouble with balance and falling backwards. So there are some specific features that we always ask. And it's something funny that we do, and again, I don't want to reveal the secrets of the trade. When you go see your neurologist, he's gonna ask you, how's your memory? Do you have hallucinations? And you have no idea why we're asking that. When we're in reality, actuality, we're asking you, do you have Lewy bodies? And then we will say, hey, do you feel lightheadedness when you stand? Do you faint a lot? Do you have trouble? We're not asking those questions. We're asking, do you have multiple system atrophy? And it's something that we have to review every single visit. So every single visit, we will always be, because we don't want to mix apples and oranges. That's the
Got it. Makes sense.
There are other things that we also ask. You know, a lot of people who goes to my clinic, I show them 2 little boxes of stuff that they can smell with their eyes closed: constipation, REM sleep, cognitive changes, mood. So you're gonna see that beyond the tremor, the rigidity, and the slow movements, there's a lot of other things that will affect you if you have Parkinson's disease. You might not have those, but we have to be on the lookout, you know? So it's not guaranteed. The basic, the classic is these 3, but some people will have a lot of constipation, some people will have a lot of trouble sleeping. So we're always monitoring for what we call non-motor symptoms. This is a typical progression of the disease. And this graph is a classic graph, and it shows when we make the diagnosis. So we make the diagnosis kind of here when you develop the tremor. So the tremor is the tip of the iceberg. And it's the $1 million question that everybody asks is like, how long have you had this disease for? Well, probably for 10 or 20 years. It's difficult for us even to know, because it's basically the question we're still hunting for, you know, is the holy grail or the missing link. What makes me lose dopamine? Why me? We have cases of twins with identical genes. Why me? Why now? We are all losing dopamine, but why did I start losing dopamine so much now? Why did I cross the threshold? Why did I have Parkinson's disease at 65? Why Michael J. Fox had it at 35? You know, so why did he cross that barrier? Was it a head trauma that I had when I was 20? Was it the exposure to toxins when I was 40? We don't know. We're still looking for that event. A lot of things increase the risk of Parkinson's disease, but there has not been a single thing that we can say, okay, this is what causes. A lot of interest is now in the gut biome. You know, if you have a healthy gut, if you have a healthy diet, how's the bacteria there? Is it an inflammation? And that is interesting because there are companies now developing medications for the gut microbiome. There are companies developing medications right now, as we speak, for inflammation in the gut, inflammation in the body that could be leading to Parkinson's disease. Genetics is important, but like I said to you, it doesn't determine if you have Parkinson's disease. Because we're now in the day and age of genetic testing, 23andMe, Ancestry DNA, Generation PD. And a lot of people say, okay, I have the gene. Does it mean that I will have Parkinson's disease? No, not at all. Not even remotely. it increases a little bit the chance of you having Parkinson's disease, but it's not even 50-50. It's like more like 15%, 20%. It's not even 50-50. And that is the same thing. People ask me the opposite. Okay, I do have Parkinson's disease. Don't you want to know which gene caused this? Well, there is no gene that causes it. If we do a genetic testing, we can only find out if you have a gene that increased the chance of you having it. So that is why a lot of times it's not practical, it's not useful to do genetic testing. We try to do as much as possible, so we increase the knowledge, and so we can also guide you through clinical trials. So because we don't have a good test, we use this clinical signs, these clinical features. And the Movement Disorder Society put together a diagnostic criteria, and the hallmark is still gonna be the three things: tremor, rigidity, and bradykinesia. I think that even the UK Brain Bank also do the same. I think that what is gonna shock you is the next slide is how accurate are we, right? Like, it can be that good. Well, we're pretty good. Okay, so if you come see a movement disorder specialist, the chance of he got it right the first time is 82%. And the second time you see him in 6 months is 88%. So it's a pretty high, and it keeps going up. If you see him 3 times, it's gonna jump to 92%, and then 94, and then 97%. Because it's a progressive disease. So if you have a little bit of tremor today, a year from now, you're gonna have a little bit more. So it's gonna be a little bit easier for us to see that resting tremor, that stiffness, together with the response to the medication. Last time I was here, somebody asked, hey, should I see a general neurologist? Should I see a movement disorder specialist? And I brought this study that compares the accuracy of a general neurologist. So a general neurologist, they do a pretty good job, you know? It's just that it's the only thing that I do for a living, you know? I don't see seizures, I don't see MS, I don't see strokes, I don't see dementia, I only see Parkinson. So I guess I'm used to seeing more. I had this very funny exchange with a patient today, a new patient, and she said something like, when you're Smith, all you see is nails, something like that. And what she wanted to reply was like, oh, because I see Parkinson's disease every day, everything that I see is Parkinson's. So if you shake a little bit, I think you have Parkinson's. And it couldn't be farther from the reality. Because I do this for a living, my job is not to make a diagnosis. My job is to separate who has and who hasn't, you know? So a lot of times, I'm lucky enough to say, you know what, you don't have Parkinson's disease. This is just a side effect from something else. Move on. So Parkinson's disease still is a challenge. And I think it brings us to how can we bridge that? How can we move on? You know, is it gonna be scans? Is it gonna be genetic testing? Is it gonna be blood work? Is it gonna be AI? What is that gonna do it for us? And we don't wanna be right, and we don't wanna not do tests. We would, if we could. It's just that the physical exam, which is readily available to you guys, is very accurate and it's very affordable, you know? You don't have to get injections of products, you don't have to be in a scanner, you don't have to go places. You just go talk to your doctor, boom. In 30 minutes, in 40 minutes, you will have a diagnosis. But the technology is no doubt advancing. And here I separate a little bit in imaging, blood work, and then genetic testing. Imaging, so even MRIs. MRIs are getting better. Right now, MRI is not useful for Parkinson's disease, but it's getting better. So one of the things that the MRI is happening to MRIs is the increase in resolution. With better and better resolution, we can see the midbrain and the substantia nigra even better. And there is this missing swallow tail sign. Swallow here being a bird. I don't know. You guys are Americans, you should know. I guess it's a bird here. And I also didn't know what the hot cross bun is. I guess it's this. Never had one. Maybe you guys should bring me one. And a hummingbird sign. So these are things you can see on the MRI that can guide you towards MSA in the hot cross bun sign or PSP in the hummingbird sign. So are these enough to confirm? No, your doctor will take pieces of the puzzles and put it together. We always recommend an MRI, and it's basically because you don't wanna be missing a diagnosis. You don't wanna be overlooking a stroke, a bleed, or something worse than that, you know? So you always will have an MRI to establish a baseline so we can look at your brain, the size of your brain, if you have any scars. Like I said, they're getting better, and now they're measuring the volume, you know, so computers, not doctors, computers are measuring automatically the size, the volume, the 3D volume of certain areas of the brain. And they're now associating these with diseases. Function MRI is also a thing. I think most of you guys have heard of PET scans. PET scan is a funny machine, and you can use a PET scan for a lot of stuff. The classical utilization of a PET scan is to look for cancers, right? So if somebody has a breast cancer or a lung cancer, they will go through a PET scan. It's because they can detect cancers and metastases and stuff like that. In this case, we use a slightly different contrast and we focus on the brain. We focus the camera on the brain, and we're not looking for cancer here. We're looking for the brain activity. Who is eating sugar? And based on that pattern, we can basically say, okay, your basal ganglia is not very good. Basal ganglia is the main part of the brain that controls movement in Parkinson's disease. So FDG PET scans are used, Yukon has it, and we go to some patients, but it still is not 100% accurate. And it still is considered an investigational study, so some insurance will not approve, and sometimes we don't even do it. But based on the pattern, we can, especially in this article, they Tune and colleagues, they describe ways of separating, you know, oh, people with Parkinson's have this pattern, people with MSA have this pattern. So they compare a lot of things, including Alzheimer's disease, frontotemporal dementia. So they were trying to create a roadmap for the next person when they have do a scan. Do we recommend a PET scan? We don't, you know, so it's still experimental. I think it's getting there, but not there just yet. What is there just yet is gonna be the DET scans, which is a funny PET scan. So the DET scan will measure the amount of dopamine that you have in your brain. And this is the result of a DET scan. So this is a normal DET scan, and you're gonna see the dopamine brightness on the left side of the screen. So this brightness is the normal brightness. What you see in people with Parkinson's disease is the lack of brightness, the lack of dopamine. And this study is used all over the world, you know, is mostly recommended for difficult cases, you know, so if you're not sure if somebody has essential tremor or Parkinson's disease, the FDA approved this in 2011 to separate and answer that question. Isn't it obvious, Bernardo? Well, it's obvious 80% of the time. 20% of the time is pretty difficult. So the DET scan can help with that. The problem is, again, the accuracy. And a lot of people, you know, it's funny how people are oblivious to this. There's a lot of false positives and there's a lot of false negatives. It's not because you did a test and the test was positive that you have the disease, you know? It comes to mind HIV. If you do an HIV test and it's positive, it doesn't mean you have HIV. It means that you have to test it again. And it means that you need to confirm it because there's a lot of cross reaction and false negatives. So you want to confirm a test. The DET scan, the accuracy is around 84%, and again, is evolving, is getting better. How is it getting better? AI, so they're measuring how much brightness in those pictures. Because when the DET scan was released, a doctor would look at those pictures and say, think this side is more dark than this side. Now they're using computers to measure the pixels and like, okay, the brightness here is actually different. And to establish cutoffs, right? So how much difference is significant. That scan is done in a bunch of hospitals, but not all. And there is a little bit of commercial pressure as well. So a big radiology conglomerate from Hartford, they stopped doing DAT scans. Why? Because they lose money doing DAT scans. The contrast is very expensive. It's a very safe contrast, but the contrast doesn't last very long. It's almost like those glow sticks. Once you pop it open, you'll have 6 hours to do the DAT scan. So once you break it open, you have 6 hours to get the scan. And they break it open in Texas. So you break it open in Texas, they put on an airplane, they ship to Connecticut, and you have 4 hours to do it, you know, so things get really narrow on the DAT scan. And if you go do a DAT scan and you give up in the middle, the hospital will be super upset because they will be like, we're losing so much money on this. All major academic hospitals still do it, you know, so UConn does it, Yale does it, a bunch of other places do the DAT scan. So it's something that we use it a lot. Here is where in the cell is the DAT, the dopamine transporter, and what glows when we use the contrast, the ioflupine. So now we're moving to a different set of testing, which is blood work. And you guys saw this huge review from the Michael J. Fox Foundation that they found alpha-synuclein in the CSF, in the spinal fluid. So this is very impressive because now we can see a biomarker, a piece of protein that should not exist in the spinal fluid, in the fluid that surrounds your brain. So it's very accurate. So the accuracy of these tests are like 93, 97, 99% accurate. And you can find the alpha-synuclein not only in the CSF, not only in the blood, but also in the skin. And that's the thing that we're using these days at UConn is the skin biopsy to look for alpha-synuclein protein. So the test is called SYN1. And basically what we do is we take pieces of your skin, look under the microscope, look at the nerves inside your skin, and look inside the nerves, inside your skin. And inside these nerves, we're gonna see the protein there. And if it glows with this contrast, it means that you have the abnormal. So here I put some numbers, and you're gonna see how high are the numbers, you know, like 97, 99%. Basically what these numbers mean is when we do this biopsy, the chance of we finding this protein, if you have Parkinson's disease, is 95%. If we do see the protein, the chance that we are correct, also known as specificity, 99%. If we see it, there is no unseen. If you miss, there's a 5 to 6% chance you just missed. And here I broke down the numbers as well, because if you do this skin biopsy, we do 3 places. We do on the shoulder, I think this is the next picture. So we do on the shoulder, on the thigh, and on the ankle. So why do we do 3 pieces? We do 3 pieces to increase the chance of finding the protein. And if you look at the numbers, if you do 1 piece only, they would miss on like 26% of people. If they do 2 pieces, well, they only miss on 10% of people. And when they do 3 pieces, they miss only on 2% of people. So increases the ability to detect the sensitivity. I think we are early adopters on the skin biopsy, but we're very satisfied with the results so far. You know, the accuracy is good. We're gonna be running a study at UConn where we're gonna compare the results of the skin biopsy with the results of the DAT scan, with the results of the doctor's exam, to make sure that they agree, right? Because some of these studies were produced by pharma. So how is this biopsy? Is it a big deal? No, it's a pretty easy biopsy. We do local anesthesia and we do what we call a punch biopsy. A punch biopsy is when you grab an instrument that looks like a pen and we punch your skin with this instrument. And the piece of skin that we collect, it looks like the tip of a pen, you know, so it's that small. And we put on a little vial and we ship this to the lab, which is outside Connecticut. So we do one here on the shoulder, one here on the thigh. I know this picture is showing the person. This is from the manufacturer, by the way. But we don't do laying down, you know, it's too much work. You know, patients don't want to do that. We basically we have them sit down on one of our exam chairs. And then I'm not a little bit tall. The chair goes way up there. But it's fun. It's almost like a roller coaster ride. But then the Michael J. Fox is also checking this and many other proteins in the CSF, in the blood, and there is a repository, right? So you're always gonna receive some communication from the Parkinson Study Group or the Michael J. Fox Foundation saying, hey, would you like to come here and donate your blood? And you're like, why would I do that? Well, because if you don't do, we will never find what is the missing link. And they're gonna say, I hate to say this, but would you come here and do an MRI? And you're like, really? That's a 2-hour test. Why would I sign up for that? Well, because if you don't, we will never find a way to make a diagnosis. And sometimes we go above and beyond. We say, okay, can I do a little spinal tap? That is more difficult to convince people. But we do need that because it's with a spinal tap, with a gut biopsy, with an endoscopy, that we might be able to bring you something more accurate. You know, you want to know, like, okay, this is what is happening to me. The same thing applies to genetic testing. I think there is a generation study that they're doing genetic testing for everybody who has Parkinson's disease. So if you have Parkinson's disease and you access their website, they basically do genetic testing. These all started kind of in New York City as well. You know, some Jewish families, they had a genetic predisposition for Parkinson's disease and other autosomal dominant diseases. And there was this very famous physician from Israel. He was working here at Columbia for some years, so he developed a lot of studies, and he really highlighted the importance of genetic testing. So it was a great work. So here you're gonna see the list of genetic testing, you know. So it is weird because the list and the number of genes keeps growing, and the more we study, the more we find, and the more we find, the more we have to be aware of. Somebody once bought one of these commercial, you know, you get on Christmas, commercial genetic testing, and she looked at me and she said, well, I know I don't have Parkinson's disease because the genetic test was negative. And I said, well, that is actually not true, because the genetic test means that you have the same chance as me and everybody else. And that chance is not 0. If you have a gene, your chance is just 10 times bigger. But it's actually 10 to 15% bigger. It's not actually 10 times bigger. It's 15% bigger. But, you know, we still have to do that. So here I listed a bunch of these commercial kits that you can do. But I think that the take home from this slide is this. It's a Pandora box, you know? So when you do genetic testing, you don't know what you're gonna get. And you don't know what you're gonna know. And do you actually wanna know? I don't know if you wanna know what you don't wanna know. So it's very weird. The most disappointing, and I'm gonna say it the last time, is that it does not tell you if you will have or not the disease. So it's gonna be disappointing, you know, so the reliability. There are some weird studies about the reliability of these guys that they do on twins, and they come completely different. And yeah, it's stuff like, oh, you're Irish and your twin sister is African. Like, what? But they're getting better. And, reading the news, like if you like conspiracy theories, the FBI is now can track you with your genetic testing with tremendous accuracy, even if you haven't done genetic testing. Even if you haven't done, they know your genetic code. Crazy stuff. So what I'm in this slide, I'm giving you a couple examples just to exemplify precisely and specifically with numbers. So if you have the GBA gene, well, 10% of patients with Parkinson's disease have the gene, not 100%, only 10%. What if you do have the gene? 10% will have Parkinson's disease, so it's not 100% either. So either way, if you have Parkinson's disease and if you check, there is only 10% chance that you will have this gene. What if you do have the gene? If your daughter has the gene, well, her chance is still gonna be only 10%. And there's over 300 mutations, so it keeps finding more and more and more. On the LRRK2, which is one of the most famous genes for Parkinson's disease, also only 5 to 15% of patients will have Parkinson's disease. And there is this thing called incomplete penetrance, which means even if you have the gene, it depends on the size, the number of mutations, it just keeps getting more and more complex. So this is the PD generation and should have links. I work very closely with the American Parkinson's Disease Association, and they are also trying to do genetic testing and financial support for patients, so there's a lot that they do in terms of testing. There are other things that you can do, so at the University of Pennsylvania, they developed a smell kit, and they were able to detect Parkinson's disease just by your sense of smell. It sounds far-fetched, but they were pretty good in their numbers, like 67%. They would agree with the results of the DAT scan. And that's something you do in the office. You just smell the thing, and it's called the University of Pennsylvania Smell Test, Index Test. So why do we need to do all of this? Because we want early diagnosis, we want accurate diagnosis, we want the support, and we want target therapies. So when you come to see me and you do a DAT scan, how accurate is that? 82%. You want 100% because you're gonna plan your life based on 100%. Like, should I sell my stock? Should I move to Arizona? What is that I'm doing here? We don't want you to think like that. We want you to think like, okay, life goes on. We're just gonna have to adjust. We're just gonna have to get stronger, healthier, and do stuff like that. But the early diagnosis is important because we want you to exercise early. We want you to know what is going on. We want you to prepare for what is going on. The same thing applies to target therapies. And like I kind of hinted for you guys now, there are some companies developing medications specifically to destroy alpha-synuclein. So you can't just finish recruiting for a clinical trial of a new medication that destroys alpha-synuclein. A lot of you guys didn't know and stuff like that is because it was a very specific study with brand new patients recently diagnosed within 2 years who is not taking dopamine. So it was a very select group of people. Because, and a lot of people like, dude, what about me? Why not all of us? It's because for you to develop a medication and a drug like this, you want the cleanest, more neutral patient possible. So you want somebody who absolutely has Parkinson's disease, somebody who has never been contaminated with any other medication or treatment for you to make a decision. So we're still waiting for the results of that one, but these treatments are what we call disease-modifying treatments. It's not something you take and you feel better. It's something you take and you feel cured. So that's why these therapies are so important. That's why we need to know, is it the microbiome? Is it the inflammation? There is a second company from here, from New Haven, and they're developing these anti-inflammatory medication, anti-inflammation medication, that they're like, these could change the course of the disease. This could stop the progression. So this is real, and this is actually happening. Another reason why you want to know exactly what you have is to gain access to something like the brain simulation. You're gonna have a presentation next month about DBS here at the RBNA Health. It's because it's an excellent therapy for Parkinson's disease. 97% improvement for Parkinson's disease, meaning that if you have MSA, it's not guaranteed that you're gonna get better. If you have PSP, you're not gonna get better. If you have cortical basal degeneration, you're not gonna get better. So knowing that you absolutely have Parkinson's disease will credential you to have the brain stimulation or the other things. I just wanted to finish by saying, you know, there's a lot of people who will get involved in your care. And if you go to a center of reference like ours, you know, you're gonna see a neurologist, a nurse, a social worker, support groups, you know, so we always stimulate. The reason why I'm here today is because we feel that we're in this together, and it takes a village to take care of each other. A lot of times we talk to patients, and they're very concerned of not disturbing other people's life. You know, they don't want to be a burden to people, they don't want to ask for favors and stuff like that. And what I tell them is that we all do that. We all rely on each other. I'm only here because my wife is paying the bills right now, you know? My son only goes to school because I go to work. So there isn't the interdependence of all levels, in all stages of life, you know? So we always depend on each other, and you should take advantage of that, you know? I saw somewhere that the key for happiness is having meaningful connections with people. So I think that's what we try to foster. You know, we want you to share, we want you to connect, we want you to learn, we want you to heal. And I think that's all I wanted to say. But I'll be open for questions, please ask me anything.
Excellent. So good. I, of course, have a question.
Yeah.
Yeah, okay. So I heard talking about diagnosis. These are just sort of like, you might laugh when I ask you these questions, whatever. But
Good question.
I've heard of a study about like using, like testing earwax. Two things, earwax and dogs sniffing people. Like, how accurate is that? Is that like a legit thing? Is that something that's coming up the pike? And what do you think?
It is a legit thing. It's not accurate enough,
Mhm.
right? So I think we are the landmark to beat, right? So if I can see you, examine you, and I'm 82%, if I bring a beagle, which is a dog, that smells Parkinson's disease 25% of the time,
Mhm.
that's great, but it's not 100%.
Right.
Number two, you also have to scale that, right? So you can have a great beagle that detects 70%. But is this beagle gonna travel everywhere? How can he teach other beagles? And what happens if that beagle dies? So
It's a good point.
these are legit studies, and this is legit technology. So ours, apparently we do have a smell, and it depends on what you're producing in terms of toxins, in terms of hormones, and in terms of alpha-synuclein. So supposedly what they're smelling is the alpha-synuclein, smell.
Mhm.
So it is true, and they are moving towards that detection. So and I was having this conversation with a medical student, which is like, the medical student asked me, wouldn't it be easier and more likely to get the alpha-synuclein from the intestine? I'm like, yes, probably. But which one do you think is easier, a colonoscopy or a skin biopsy? You know, so it also has to be practical.
Mhm.
So that's why the skin biopsy we're utilizing more than the spinal tap, because the spinal tap is a harder sell.
Mhm.
But the answer to your question is yes, these are legit, and they are developing those.
So the earwax though, like what are they looking at?
They're looking
Also the alpha-synuclein?
Alpha-synuclein, yeah, so they're looking for that. And same thing on the skin, they're trying to look everywhere, they're trying to look at in the hair, because imagine if I could get one strand of hair,
Right.
easy, right?
Mhm.
We don't wanna do anesthesia and punch biopsies and stuff like
Right.
that. So, yes, this is actually happening.
Anyway,
You got anything? Oh, because we could stay here all day. Okay, where should we start? That's how, when we're talking about, it sounds like the gold standard is still your clinical exam. That's where it starts, and then you're 80–90% accurate, so then you're looking for that extra bump to get it to 100% accuracy, and that's what we go into our imaging. And I love, do you video everyone?
I wanna say yes, because my colleagues, they're always on my case, that we should. So videoing is labor intensive, and nowadays, hospitals, they want us to see patients every 30 minutes. So for us to obtain video of a patient, we need to sign a consent, which in itself takes time. We have to get some specialized videos. So we tend to video all the new patients and all the interesting patients, but we don't video patients every time. So such as follow-ups, we see like 20 people per day. That would be ideal, and we would love to do that, especially for teaching, but also for follow-ups. I wanted to say that the gold standard in life is physical exam, but the gold standard is actually pathology. So the only way to absolutely confirm Parkinson's disease is with autopsy after death. Meaning autopsy is not biopsy, it's not taking a piece of brain. It's like slicing and dicing the brain and looking everywhere for alpha-synuclein and Lewy bodies. So that's the standard of care after life. But in life, we still use the physical exam as the standard to be beaten. Your doctor will tell you if they will need more tests or not. And we don't want you guys to assume your doctor will always order the DET scan or the skin biopsy. But I also don't want you to assume that your doctor is not good if he does. And it's funny because I say these very controversial things. So when is that I do a DET scan? I do a DET scan when I'm not sure what's going on, when the patient is not sure, or when I don't like the patient.
Okay.
And what I mean by that is like, if we're having a shaky relationship and like, okay, you don't trust me,
Yeah.
let's do the DET scan. Because I think that is almost a confirmation of what I already knew. But for patients who trust us, who trust our judgment, our assessment, and when the case is classical, it becomes futile, and we don't want to waste your time, we don't want to waste your money, so there will be a variation, a lot of variation with each patient in each encounter. But
I've had some patients tell me, well, we weren't sure, so he just put me on a little carbidopa and see how I do, and turns out I do okay, so I guess I have Parkinson's, but that wasn't, is that an option, or would you go the imaging route for confirmation versus giving medication?
So it's a tricky business to give medication to people, but yes, on the Movement Disorder Society criteria, they list response to levodopa as a supportive criteria. It's not a main criteria, but it's supportive. Because you have to think about it. If it is a disease that you're missing dopamine, if you give dopamine and they get better, well, that is a very good confirmation. But it's a confirmation of what you already are suspecting. Because, again, only 95% of patients with Parkinson's disease will get better with treatment. Only 95. Well, it's a huge chance of getting better, right? But there is 5% of people who will not get better. They still do have Parkinson's disease. They could have a PSP who does not respond to Cinemat by definition. So PSP does not respond to simulate. And there is always the placebo effect, so you can give jelly beans to people and they might stop shaking. And it is a real powerful thing.
Can we talk more about the alpha-synuclein? So it sounds like everyone has it. It's a normal protein when it's in its correct form.
Correct.
It's this misshapen that is the issue. So when you're biopsying, you're not looking for the presence, you're looking for the presence of the misshapen alpha-synuclein.
Correct.
Okay.
That is 100% correct. It's what we call phosphorylated.
Okay.
So they specific test for phosphorylated alpha-synuclein.
And it's because of its presence, the brain is not doing its thing to produce the dopamine. So if we go backwards, if it just didn't misshape, there would be no Parkinson's. So if we can prevent the misshaping, we would solve all of the problems of the world.
Well, those
Is
are
that what the- is that where
those
we're
are big
going with it?
assumptions, but that is the most prominent train of thought.
Okay.
But I think you have to understand that it's not only preventing the misfolding, is finding out why he's getting misfolded to begin with, So the problem might not even be on alpha-synuclein. It could be something else that the alpha-synuclein is folding to prevent or to fix, but it's still not fixing.
And then how does the folded alpha-synuclein get to the lack of dopamine?
So
What's that connection?
we don't know that connection yet. We know that a misfolded alpha-synuclein tends to clump together, and a misfolded alpha-synuclein tends to clump so much that will become this ball that we call the Lewy body. So we don't know exactly how it happens. So the alpha-synuclein is part of the trash processor mechanism of the cell, okay? The proteasome ubiquitin complex. So it's part of this trash compactor, trash processor machinery that we have in the cell. So there's a lot of garbage that happens in the cell, and it has to be processed and recycled, and it gets recycled. So something happens with that system, and the alpha-synuclein not being there, not being useful, not making to the protein, that seems to be what causes the cell death. But we don't know.
And the cell death that would be producing dopamine.
The death of the cells that produce dopamine, right? So these are
Okay.
specific to dopaminergic cells.
So when we talk about some of the new upcoming targeted therapy, not just symptom reducing, but targeting the disease for the cure, we're getting rid of alpha-synuclein, but you mean just the misfolded or all of it? Because it sounds like we still need alpha-synuclein in its original form, so why would we get rid of it?
These are great, excellent questions. The answer is yes, yes, and yes.
Okay,
Because we don't know exactly what is happening, we're testing,
gotcha.
okay? So we're testing the easiest thing. We have a lot of misfolded. What happens if we destroy the misfolded? Would that be enough to stop the disease? Yes. But they are also testing at the genetic level. What if I move the gene and stop producing the abnormal alpha-synuclein? So they're also testing those. So there is a few years ago, 5 years ago, they developed this technology, and it's all about technology, right? You know how we now are super capable of making vaccines because now they know how to make vaccines. So there is this new genetic technology called antisense oligonucleotides, and it basically means that we're now able to make small oligonucleotides that will link to the gene and stop the production of these abnormal proteins. So they are actually testing ASO, antisense oligonucleotides, to see if they can block the gene that makes the protein to begin with. So not even produce the protein. But the jury's still out, because this technology is being tested for several diseases. I'm gonna give you an example of Huntington's disease. Huntington's disease is a genetic disease that the gene makes this weird protein called Huntington protein, and the Huntington protein kills the brain cells. So in the same way, there are medications targeting the already red protein, and there are these oligonucleotides that block the gene. The problem, even on Huntington's, and you're learning from other diseases what happens to those, is that you cannot clip, and now we have technology to cut genes out. The cells don't live without that gene, so it's essential for life. So you cannot snipe it out, you cannot cut it out. Because like I was just referring to, it's part of the natural machinery that destroy and process proteins in the cell and recycling system. So it's a very complex situation. Of course, and you have to think also on the levels of science, phase 1, phase 2, phase 3, animal models and stuff like that. I'm not gonna cut his genetic code. So we have to do that in mice. So we cut the mice. And then we're like, okay, this was great. And it worked and we clipped and everything. When we went to bigger animals like primates, it went downhill. Like they didn't tolerate well, living without alpha-synuclein. So that is basically what scientists are doing every day nowadays, is testing on every single checkpoint where they can change the disease, maybe a medication. So the study that we did at UConn is a national study. It's not like we did, it's a national study. It is a tablet that attacks the ready abnormal protein and destroys it. We see jury see off.
A DAT scan, layman's terms, is easy. This Parkinson's is a lack of dopamine. Let's do a scan to see your dopamine levels, but really we're looking at the dopamine transporter.
Correct.
So if it's a lack of dopamine transporter, it's assumed it's a lack of dopamine, or it doesn't matter, the dopamine is not being transported. Can you have adequate transporter but a lack of dopamine, then you have a false negative on the DAT scan? Does that make sense?
Yeah.
Question, okay.
Makes a lot of sense. So here's the dopamine transporter. That's a great question, and it's a very complex question, okay? Like
Sorry.
fellow level. So yes, we're not measuring dopamine. You're absolutely right. I kind of lied to you a little bit, okay? White lie, half lie. You're not measuring the dopamine level. You're measuring the amount of dopamine transporter. However, the dopamine transporter is part of this neuron here. And this neuron here is the one that produces dopamine. So the only way you will not have a dopamine transporter is if this guy is dead.
Gotcha.
So we're actually measuring how many of these guys are alive. Because if they are alive, they will glow here.
Yes.
And this is something we tell medical students and residents and fellows. This guy is on the substantia nigra. So this is a substantia nigra neuron going to the basal ganglia.
Gotcha.
So that's why we see the basal ganglia glowing. We see the basal ganglia glowing, but it actually tells you the life and the health of your substantia nigra. So it's an indirect pathway. It does have false negatives because the contrast has to attach to this. Guess who else attached to this? Cocaine. So if you do cocaine and you don't do a DET scan, this is gonna be already occupied, so it's not gonna glow. In that way, there are few medications you cannot use. There are few medications you cannot use because some of these medications will latch to this.
Okay.
And will make the DET scan not very reliable. In general, we're able to stop these antidepressants a few days, a week before, and get a very good, reliable DET scan. So.
Can I just ask a quick question? What, based on what she said something earlier, is you said PSP doesn't respond to dopamine. Are there any of those other atypical Parkinson's that also would lead you that way because they don't respond?
So how well they respond also matters, you know, so we observe all of them. So I didn't separate these in three, but it should have a line here separating
Okay.
these three. Because Parkinson's disease, Lewy bodies, and MSA, they do typically respond to cinnamate, to dopamine, sorry, to carbidopa, levodopa, and they typically are considered to be cousins. And they typically progress slower and are much more benign. They have their own issues, especially these two guys. But these top three, they are part of a certain family. The alpha-synuclein
Synuclein.
family.
Got it.
These other guys here
Are the tau.
are the tau
Mhm.
proteins. So these are considered to be tauopathies, and these are alpha-synucleinopathies.
Which is also more Alzheimer's, is also the tau.
Yes, Alzheimer is also a tau disease. However, it's not a Parkinsonism.
Right.
So the pathology involved in Alzheimer's is also caused by this weird protein called tau. There are other diseases that are caused by alpha-synuclein, one of them being autonomic dysfunction. The pure autonomic failure, for example, is caused by alpha-synuclein. It's not a type of Parkinson's disease, but
Right.
it
So
also
could you
causes
have Alzheimer's and Parkinson's disease, or would you rethink, because the dementia came on first, really, or would you rethink the whole thing and be like, oh, this person's atypical Parkinson's, or can they have both?
Of course, they can have both. You know,
Okay.
it's not forbidden, unfortunately. And again, this population has high risk for both, right? So
Okay.
somebody in their 60s, somebody in their 70s, is typically when Alzheimer's starts. It's typically when Parkinson's disease starts. So we always have to be on the lookout. So from the first visit throughout your follow-up in a Parkinson's disease clinic, you will be asked that question: how's your memory? Who do you live with? Do you drive well? Have you had any recent car accidents? Do you manage your own finances? These are all the same questions. Do you have dementia? So, and that is a great question, very difficult to answer, and you have to really be judgmental. You can have both, of course you can have both. Alzheimer's and Lewy bodies, they have slightly different dementias, okay? So there are certain clues you're gonna get. Timing is very important, okay? So if you have Parkinson's disease and you don't have dementia within the first 5 years, you don't have Lewy bodies, okay? So if you eventually develop dementia, it's likely it's gonna be Alzheimer's or vascular dementia. There's a bunch of possibilities. But sometimes we're in a pickle, like, okay, the dementia came first. Was it Alzheimer's or is it Lewy body? They're slightly different in the sense that Alzheimer's is what we call a cortical dementia, and Lewy body is a subcortical dementia. How can I tell? I don't know, difficult. But cortical dementia will give you end result problem, like I cannot find the word. It's not about thinking, it's about getting it out. Which a subcortical is about connections. So a subcortical dementia, like Lewy bodies, is like, I don't know how to use this microwave thing, you know, I can't figure it out. I can't figure out how I use my clothing and stuff like that. A person with Alzheimer's will know how to use a microwave, but will not be able to say the word microwave. You know, it's a very word finding difficulty, is very end result. A dementia with Lewy bodies also will have a lot more visual dementia, if I can say that. And the classical description is visual hallucinations, but it's not as simple as visual hallucination. It's visual connection problems. So it's again a subcortical visual problem. It's not that they're blind, they can see. It's what they can see is gonna be misinterpreted. So they will have visual illusions, visual hallucinations, they will have depth perception problems, they will think they saw something, you know, there will be some confabulation, some illusions, because their vision is gonna be weird. Even when they look at patterns, they will see wavy movements on the patterns. They will say that they have double vision, but they don't actually do have double vision. So the putting together of the images in the brain, understanding the images is messed up. Alzheimer's, and again, looking at the PET scans, I don't know where is the PET scans, but when you look at the PET scans, you're gonna see that somebody with Alzheimer's disease, they will have more parietal lobe problems, so the location is slightly different of the dysfunction. So people with Alzheimer's, they will have a more cortical dementia. So, but it's difficult. And it's very difficult, and you might need to go and do a PET scan. And like, okay, why are we doing a PET scan again? Well, because you have this dementia, now I don't know, you're throwing me off. And nowadays, and I'm not talking about Alzheimer's today, but nowadays, they also found that our little biomarker in their cerebrospinal fluid, not alpha-synuclein like us, but tau. So how do you make a diagnosis of Alzheimer's disease these days? You do a spinal tap, you collect the fluid, and you check for tau protein, phosphorylated tau, beta amyloid, and tau. So you do check for those biomarkers on CSF. That's how you do a diagnosis. The problem is that I do have a patient who did have the spinal tap, which was positive for tau, and he had the skin biopsy, which was positive for alpha-synuclein. So he has.
Can they look for both in the spinal fluid for both alpha-synuclein and tau, or they can only
I don't think that
specifically?
the CSF alpha-synuclein is commercially available.
Oh, gotcha.
So it's not because Michael J. Fox released the result of study that is commercially available.
Right.
The
Okay.
skin biopsy took like 4 years to be
So
commercially available.
did your person have both
Yes.
symptomatically, like on
Yeah.
physical exam? Okay.
Yeah, he has Parkinson's disease and he has Alzheimer's. Because it doesn't sound like he had Lewy bodies, and we're like, okay, this is weird, but weird happens.
Do you have like a percentage? Not really, of like,
Not
it's
really.
just random. Okay.
Yeah.
Just curious.
Because even the spinal tap is kind of new. Alzheimer's for many, many, many years, just like Parkinson's disease, has been a clinical diagnosis, right? So this, I did it.
No, we got it.
So Alzheimer's for many, many years, just like Parkinson's disease, has been a clinical diagnosis. You would do memory tests and the progression would be revealed. But now we're moving to the CSF. So it's a pretty new stuff. And the reason why we're going for CSF for the diagnosis of Alzheimer's is because now we're developing new and specific treatments for Alzheimer's, new infusions from these companies. So when you're using a $20,000 per year medication that you have to come to the clinic every week to get an infusion, that you have to get an MRI every month, you want to be very sure, that you have Alzheimer's. So kind of the same will happen eventually with Parkinson's disease. If we find a medication that really changes the course of alpha-synuclein, you don't want to send the PSP, you want to send the Parkinson's disease. So it's progressing to that.
So if you have vascular dementia, could progress to being both deficits of presenting like the subcortical, what did you say?
Yeah, cortical and subcortical.
Okay, so it could present to lead.
It can. And that is the difficulty of somebody dealing with dementias, is really narrowing down the diagnosis.
Yeah.
Vascular dementia can affect cortex, can affect subcortex, like the white matter. So a vascular dementia is very tough to diagnose. It's very tough to rule out. You do the MRI and you want to see vascular insult, right? So you want to see damage to the brain, but it's hard to prove, because who doesn't have vascular insult? So there's no confirmatory, so you're gonna see a lot of people using the word mixed dementia, because they're like, yeah, the MRI doesn't look good, it has scars everywhere, but the clinical pattern looks like Alzheimer's. So, and we're not super far-fetched. I think it's like 5 years ago, Alzheimer's is it has a fancy name, right? Alzheimer's. But Alzheimer's is dementia for no particular reason.
Mhm.
So you have to have no particular reason. The MRI has to be clean, the blood work has to be normal, everything has to be normal, and you have dementia. So that's used to be Alzheimer's. But Alzheimer's is moving now to like, no, you have to look for amyloid, or you have to look for tau protein.
Okay.
I had a scan earlier this year, looking for dementia, which I had trouble with. And that's when they came back and said, well, that went through, but you do have Parkinson's, by the way. Apparently, they're very close, whatever, I guess, I don't know, but,
And what scan did you get?
I can't remember, I think it was an MRI, but.
I think it's an MRI.
Yeah.
So again, these are half truths they're telling, okay? This is not super accurate. So again, is the evolving technology of the MRI. So now the MRIs, they're not relying on the doctor's eyes anymore. Is the future, we're gonna be all be replaced. Get ready. So nowadays, they're doing what I was referring Parkinson's disease, they are doing that for Alzheimer's as well. They measure the volume. Is it 100%? No, it's still not 100%. But there are specific part of the brain that is responsible for memory, supposedly, or is the memory center, called the hippocampus. You see, now I have memory problems. The hippocampus. So they now are able to measure the hippocampus. And if your hippocampus is super tiny small, they're gonna look at your doctor, and you have to pay a lot of attention to the verbiage, how they said. It's like, doctor, maybe you should consider the possibility that this guy might have dementia. Because the radiologists, they cannot make a diagnosis of dementia. They can tell your doctor, guys, did you check his memory? Did you think about Alzheimer's? Because your hippocampus is small. In the same way, like I was showing, when they do an MRI and they look at the midbrain, they can see the swallowtail test, right? So they can see what they call the nigrosome 1. So if they look at the midbrain and they look at the substantia nigra and they see that it's not that dark, they cannot call it Parkinson's disease. They will write it down. This is typically seen in people with Parkinson's disease. Maybe you should check it out. So on the report, if you pay attention to the report, the way that it's said, it will be said like that. We don't see the swallowtail. Maybe your doctor should think about Parkinson's disease, or they will write something like, this is sometimes seen in people with Parkinson's disease. So that's the language that is used officially.
Well, my mother died of Alzheimer's, but this is 20-some odd, 5 years ago. But I was always told you don't know whether it's Alzheimer's until they've died and they've looked at the brain.
Right.
Is that still the case?
That is still the case, and that is still the case for Parkinson's disease, right? So if I look at you and I say you have Parkinson's disease, 98% sure, 99% sure. The only gold standard is with autopsy. Yeah, so it's still true.
And so what at that point?
Well,
Let's postpone that test.
Yeah. I have one more, maybe
Please.
a little selfish. We
These are great
are
questions.
gonna do a presentation to PCPs about, hey, we know that the research has shown that not everyone has a neurologist with Parkinson's, and even fewer with a movement disorder specialist. We understand you might be treating these patients. What do you need to know? And just like you said, an ironsmith uses nails, and a carpenter uses a hammer, a physical therapist uses exercise. So we're gonna preach, if you're treating these people with Parkinson's, at least get them to exercise, but without hurting their egos, because
Yeah.
I'm only a PT. What would you encourage our message to be to these PCPs so that they're at least doing the best to their capability for these patients besides exercise?
I mean, it was funny how you present your question. I'm only a doctor too. And egos are always bruised, so it can be your colleague is next door, it can be your colleague within UConn, it can be a psychiatrist, it can be a different specialty. So I'd like your attention to relationships and the way that it's done. I think that we don't know is the most accurate answer to your question, but we make efforts. So UConn has a symposium every year that we invite primary care physicians, but we go beyond primary care physicians. We are very inclusive, and we think that it should be. So we invite all healthcare professionals, because a nurse can make a diagnosis of Parkinson's disease, a PT can make a. How many patients have come to my clinic because the PT said, well, you're not seeing your arm, maybe you should check it out, right? So we want to promote knowledge, and I think we're just sharing our knowledge, and it's less about, oh, you should do this, and it's more like, I think it's the way you present it, but it's more like, people really benefit from physical activity. And this has been the main constant in the care of Parkinson's disease, is how much physical activity improves response to medication, it slows down progression, improves memory, and slows down neurodegeneration. So on a cell level, on a physical exam level, on the memory side, on the balance side. So it's not only balance, even the response to the medication. So people who take the medication and they don't get a good responses, they exercise, and all of a sudden the response is better. So we do stimulate these initiatives such as this, and we do stimulate primary care physicians, general neurologists, because there's a lot of market pressure on physicians nowadays. And I'm from an old generation of physicians, and I know I look young, but I've been a physician for 21 years now, and both of my parents are physicians, so I'm used to the old school visits. And nowadays we have 10 minutes, I have patients who go to their primary care physicians, and the primary care physicians say, you can only tell me about one problem today. So like, what? What if they're all connected? We don't know. So I am lucky enough to work at a state hospital where the Commonwealth of Connecticut is the main priority. So we're less pressured, and I mean less, because Congress wants us to be fiscally responsible. So we're less pressured for time, but you're seeing a lot of that is difficult for physicians, caregivers in general. I see on the PT side, insurance, they only approve 35 sessions per year. Like, what? Who drew that line? Who
Well,
decided this?
we could talk about this forever. I mean, we really have sick care, not well care.
Yeah.
We have to change that in general. I mean, we could talk about that all day, because you get care when you're not well, but we should really prevent the sickness. So yeah, that's part of the problem.
And that's why I think that we should always invite healthcare professionals and say, hey, look at what this can do, look at this potential. And a good approach is like, hey, we can help you. Yeah. Instead of, this is one more thing you have to do. Instead of presenting as, this is one more thing you have to do, if you present it as like, hey, we can help you, and this is gonna be so much easier, your life is gonna be so much easier, your patient's gonna be so much happier.
Right, but also rewarding you for making a more accurate diagnosis versus getting paid more the more the person comes in, the more visits. But if you're more accurate, you should get more money for sending the person for exercise, for making the right choices, for making the right diagnosis, being more accurate. And we could say the same thing for PT. We get somebody better quicker, we actually get punished.
Yeah.
Because the patient doesn't come in as many times. So again, it's a
complex topic.
yes. Right. So
Well, that was an easy sales pitch for us. We didn't have to pay you to say it. Thank you very, very.
yeah,
much.
thank you so much. That was amazing, by the way. That was great.
Yeah.
It was really good. How do I stop the recording?
I think there's a button that says stop recording. Well, thank you. Maybe we'll
No.
see you next month, or I know you're busy. You tell me when you want to come back, and the door is always open. It's absolutely a pleasure having you. Thank you very,
For
very
us
much.
as well, it's always good to talk.